Good morning. How you doing?
I'm okay. How are you?
I'm well. I'm well. All right. So how's everything been going so far?
Um, I think okay. I just
Okay.
my confidence is not great.
Okay. Tell me about it.
Um, like I don't really remember any of my like previous attempts or questions or anything like that.
hmm
Um, because like to be honest, my brain's been shot sitting in that test, and then when I leave, I don't remember anything that I experienced beforehand. But like all the practice questions that I'm doing, I'm not really having a whole lot of problem with them,
Okay.
which is a good thing. Um,
Okay.
like I think I definitely retained the material. I I don't know, just where I feel in general.
Okay. Well, so what we're gonna do is we're gonna go through some questions together, just kind of see where you are. Chances are, I think you're actually probably better off than you think you are, but we'll see. Based on how I've seen you answer questions in the previous sessions, I would say that your overall knowledge is probably solid. But we'll kind of see as we go through some questions. Now, I will have to kind of do a hard stop around like 10:30 at the latest.
Yeah,
So it's supposed to be an hour session, but we'll extend it to an hour and a half. But I'll have a hard stop at 10:30 because I've got another training to do right after this.
no problem.
So, well, thanks for agreeing to swap the times with me. I had
Yeah,
a training situation that came up starting yesterday. It's to yesterday, today, and tomorrow all day. Like we went to almost 9 o'clock last night.
yeah, busy, busy man.
It's definitely gotten busy lately. The other thing that's coming out, in fact, I was actually working on it even last night. So the question bank it's now up to 700. I think it's 700 now actual questions loaded into the question bank, and we're just having to like test each question to make sure that everything routes correctly and all of that. But so that's coming. Unfortunately, that wasn't released before you needed it, but you had ample resources for sure.
I did the 100 questions last night. I was on a 24. I got off this morning, and I did the
Oh
100
wow.
questions, and I got 97.
Nice. Okay,
So
good.
I got three wrong.
Okay.
Uh, just
3
like
out
your
of a
exam, I
100?
got two wrong, but
Okay. And the things that you missed, what were they?
um, I think one I misread, which was kind of dumb. Um, It was number 14. The patient's capnography waveform is present, but the end title is steadily rising. Patients becoming drowsy. Most
Mhm.
likely explanation. I thought it was due to hyperventilation, but apparently it's hypoventilation. So
Yeah,
obviously
right.
that was kind of a misread because obviously if you're not ventilating, your CO climbs.
That's correct. Yeah,
But I
because you're
thought if I
not
was
blowing it off.
hyperventilating, they weren't getting enough, and so it was just like increasing that way as well.
No, if you're hyperventilating, you're actually breathing faster, so you're blowing off more CO2, so your end tidal CO2 goes down.
Okay.
Because
Um,
the more you that's more CO2 that you get rid of, and then your CO2 number goes down. But when you hypoventilate for whatever reason, whether it's opiate overdose, benzo overdose, alcohol, neuromuscular disorder, anything that causes you to breathe slower or more shallowly, that's going to you're not blowing off the CO2 in that case. You're holding on to it, so your CO2 level goes up.
okay. And then so I was you said just to know why answers are wrong. So I got 13 wrong also. As an adult patient with agonal respiration should be ventilated at approximately. I
Adult
hit
patient,
20 because that was the high end of our like normal of 12 to 20, but the correct
right?
answer was 10, which
But when we're
I know is the
ventilating, so in respiratory arrest,
rest.
when we're ventilating someone, we're doing one breath typically every 5 to 6 seconds.
Yeah.
So, what was the answer on that one?
It was 10.
Okay, so yeah, so 10 would be, so if we do one breath every 5 to 6 seconds, 5 to 6 in a
It'd be
minute,
6.
that's going to
Yeah.
be 10 to 12.
Yeah. And then the other one that I got wrong was.
especially, and it's even more important, especially when we're ventilating, that we don't hyperventilate, because like that, when we squeeze that BVM, that whole thing has about 1,500 cc's of air, right? So like if we were to squeeze every drop out of that bag, that's about 1,500. But a normal tidal volume is about 500 mLs. So this is why we only want to squeeze the bag with one hand, ideally. So like even if they don't have a tube and we're just using a mask, we want somebody with two hands to hold the mask with two hands, and then with one hand we squeeze. Well, actually, with just a couple of fingers we squeeze, because there again, we don't want to overdo it with the ventilations, because the same kind of situation, we're actually going to blow off their CO2. We're going to blow off too much. Um, and even in head injuries, it's kind of an old way of thinking that we hyperventilate head injuries automatically, but we actually can cause a lot more harm with the hyperventilation than not. So it's better to, unless you have some specific reason, or if the patient is requiring it, sometimes that you have to ventilate faster because that's what the patient's body needs at that moment. But otherwise, if you're taking over their airway, or if you're having to assist them, if they're properly sedated, you want to breathe them one breath every 5 to 6 seconds. So that's going to be 10 to 12 times a minute for an adult, or one breath every 2 to 3 seconds for a kid. Now then it becomes 20 to 30 times a minute for a
Yeah,
kid.
I did know those answers, but like when I was physically taking the exam, I even wrote, um, that it was low. So the notes that I took on that question was like for 6, it was low, too low. 10, I even put that it was low because the threshold for ventilation is like 10 to below 10, or less than 10, higher than 30. And I
Right.
was like, okay, so it was kind of like I was debating between 20 and 10, but I was like, I know 12 to 20 was like our normal. And then I was
Yes.
like, 30 is too high. So I was like, oh, but if I actually did like a math equation for it, I would have been appropriate to hit 10.
Okay. Okay.
Um, and then the other one that I got wrong, it was a total oversight, which I got excited and I just selected DKA, but it was 42, and it was which condition should you suspect? It was a patient with liver disease, which obviously that's my cue that I misread.
Mhm.
Liver disease is confused, has a sweet musty odor on the breath. And I was like,
Okay.
oh,
Was it
that's DKA. And then
encephalopathy?
it was actually hepatic encephalopathy and
Okay. Uh-huh.
liver, and yeah. And I like was reading that and I was like, oh my gosh. But that is what I
And
tend to do when I take
now, and
exams.
so in that situation, okay, but that's actually a good point. How did it describe? So I don't have the questions memorized, but how did they describe the breath?
Fruity, fruity musty odor.
Okay, so the musty odor, or sometimes it'll be described as like an almond. I don't know how they come up with this. Sometimes it's described as an almond odor, but so fruity typically is kind of like DKA from the ketones. The musty odor is more of the ammonia.
Mm,
Um, Kind of think of ammonia like in a cleaner, kind of that stinky smell. That type of that situation. So what's happening is the liver is failing due to whatever reason. It's not able to detoxify all this excess ammonia. The ammonia ends up getting across into the blood-brain barrier, across the blood-brain barrier, into the bloodstream, across into the brain, and that's what causes the encephalopathy part. So it's ammonia that gets into the bloodstream and then gets into the brain. And then when you have ammonia in your brain, ammonia kind of behaves like an acid. And so it starts to basically denature or destroy the brain cells. That's what leads to all the confusion, mental dullness, altered mental status, that kind of stuff.
okay. So those
Okay.
are the only ones that I got wrong.
Okay.
And
I mean, that's
then,
great. That's actually, I mean, that's great. And the thing is, you don't have to know everything. You don't even have to get every answer right to pass the test. In fact, nobody gets every answer right. The thing I want you to constantly ask yourself on the test is, what's the safest thing I could do? And the safest thing is not typically the most expensive. It's not definitely nothing outside of your scope. So the SEED, SEAD, so nothing outside of your scope, nothing that's too expensive, nothing that's too advanced too quickly. even when you have to do advanced things like intubation or whatever, there's typically something basic that you have to do before you get to that step. So, like with intubation, one of the more basic things that has to happen first, or that should happen, is pre-oxygenation, apneic oxygenation with a nasal cannula at 15 liters per minute prior to intubation. That's real basic. Nasal cannula before intubation, things like that. Um, or like, even like I said, long before you've got to intubate, there's other things that you need to do. Or long before you need to give fluids, there's probably other things for shock management that need to happen, like stopping severe bleeding, keeping them calm, keeping them warm, keeping them dry, things like that. So nothing outside of your scope, nothing that's too expensive, nothing that's too advanced, or nothing that's going to delay care. The other thing, so remember the seed tricks, and then constantly we're going to use the 5-star medic method of, number one, is there a safety concern? Basically, just kind of rehearse that in your head. Every question, is there a safety concern? Yes or no? If there's a safety concern, that trumps everything else we do, even over patient care, no matter how bad the patient is, no matter how sick or unstable they are. If there's a safety concern, that's the first priority. Whether the safety deals with BSI and we need to isolate ourselves some kind of way with some kind of equipment, whether it's that we need additional resources, whatever, or we need to not be there in the first place, we need to stage, that kind of thing. Safety is first, then sick or not sick. Okay. How do we know if they're sick? Increased respiratory rate with symptoms, increased heart rate with symptoms. How do we know that they're unstable?
Altered mental status.
Altered mental status, pale cooled clammy, pale cooled diaphoretic, delayed cap refill, hypotension. Okay. Then all of our fixes come down: oxygenation, ventilation, perfusion, if there's something to fix for a patient. Or is there a time sensitive situation where, like, if they're unstable, that we need to do something now and rapid transport? If there's a time sensitive situation, we need to rapid transport. And that seems really basic, but when you just follow it over and over and over, it's going to get you 90% of the questions correctly. And on any exam, that's passing.
So I
Okay.
think my biggest thing is that a lot of the time, like, my
Bless you.
clinical judgment is not my issue generally. So like the scenarios are generally not my problem.
Okay.
So
So,
I did also this exam, the mock exam with the scenarios, and I did that and I got 100 on that,
okay.
the 10 scenarios.
Oh,
So
wow.
like even when I like before I even found you, or you found me, but
Mhm.
even before that, I purchased medic tests and I was rocking all of that. Like the scenario questions I never had any real problem with.
Okay.
I don't know if a lot of it's test. I have so much going on in my mind, like all of that. So I don't know if it's test anxiety that is like the worst thing for me, or if I
Hmm.
just don't know what they're asking me.
Okay. All right. So let's start with some questions and we'll just kind of go from there.
Okay, doke.
Okay. Let's see. Let's blow that up. Okay. There we go. And okay, we'll just start. And I want you to kind of take the lead and say out loud what you're thinking. Now, on the real test, you're going to have to think it to yourself, or just kind of jot down little notes. But I want you to just kind of talk out loud so that I can kind of gauge what you're thinking. All right.
Okay. Um, what should the paramedic do? It's a two-step question. A 66-year-old patient has crushing chest pressure. Okay, so I would think more of a cardiac problem for him in general. He's diaphoretic, has nausea and weakness, so he's definitely sick and likely unstable. The diaphoresis is telling me he's kind of shocky. Um, the 12 lead EKG or ECG shows ST elevation in 2-3 AVF, so we're looking at an inferior. BP's hypotensive, 82/48, and a pulse rate of 44. So the 44 is likely, if it is inferior, it is because the AV node and the SA node are probably like knocked out.
Mhm.
It's involving the right atrium. Respiratory status, 20 minutes on the higher end of normal. And an SpO2 of 96. Lung sounds are clear. patient took tadalafil, so that's a PDE5 yesterday. So no
And
nitro.
PDE5 inhibitor. Okay.
So no nitro.
Okay.
What should the paramedic do? So we're not going to delay transport. Withhold nitro, consider right ventricular involvement, and transport to PCI capable care. I would say that would be the answer.
And notice that's what you actually told me. You actually said no nitro. And this
Yeah.
question says withhold nitro. Your brain came up with the answer. That's probably the answer. Okay. We'll
Well,
just,
for two reasons for that, because his blood pressure is hypotensive and because he took the PDE5 inhibitor. So both reasons he can't have
yep.
nitro.
And because there's an inferior infarct, we also want to consider, because most 85% of the time it comes from the right coronary artery. The way we're going to check that is to do
V4R.
V4R, another 12 lead, run it again. If we have elevation in this new lead called V4R, we are suspicious that yes, it's the right side for sure. What kind of reciprocal changes would we see in the EKG with a right infarct?
You would see depression
Where?
in
So it's primarily going to be posterior depression, but that means you got to put stickers on their back.
on the back.
So you may not have. I mean, you may not do that. That's why we at least move V4R, but you'd be looking for reciprocal changes. So ST depression in the posterior leads primarily. You may also have some depression in the lateral leads, but posterolateral on that. Okay. And then what about B? Why is B wrong?
Because I mean, for a couple of reasons. So his heart rate is more bradycardic, and adenosine is a tachyarrhythmia medication.
Nice. Okay, so that's enough. And then what about the nitro again?
We won't give it because
Yeah,
he's
you already
hypotensive and
said no
because he's got a
nitro.
contraindication.
So in that case, we just kind of eliminate it down to the answer, and that's you're going to use that strategy over and over and over. Just eliminate what's obviously wrong for any reason. Okay, let's go to the next one. We're going to knock out as many as we can in the time that we have.
Okay. Select the 3 correct answers. It's a 2-step.
Okay.
A 58-year-old male is in cardiac arrest.
All right, 3 priorities in cardiac arrest.
So early CPR, early defib, and early IVIO access for epi.
Okay. And then CPR, of course, consists of 2 things. That's going to be compressions and ventilations. So find 3. So in this case, we don't know the game the test writer is going to play. We don't know if they want these 3, but those are the top 3. But remember, since this is like 2, this could be counted as 1, 2, 3. So just find some combination that matches whatever the test writer wants.
Without going any further?
Uh-huh. I mean, we
Okay.
got this patient's in cardiac arrest, so
Okay.
it doesn't really matter. Now, well, this part would be important just because that determines if they're in a shockable rhythm or
He's a
not,
shockable. Yeah.
because we only defib the 2 that are shockable. What are the 2 that are shockable?
Pulseless VTAC and VFib.
Pulseless VTAC and VFib. Okay. All right. And he's in VFib. He is in a shockable one, so defib would apply. Find me 3 things that match. Let's start
So
with
it
the
would
bottom.
not be F because he's
Okay.
unconscious and we wouldn't give nitro. He is unstable, so we're not going to be giving pacing.
Okay. But we do pace unstable. It's just that's unstable bradycardia. He doesn't have a heartbeat.
Right. So, the only reason you would pace there is if you got ROSC and you couldn't maintain the map.
Correct.
So that wouldn't be right. You wouldn't be using a synchronized cardioversion because he's unstable and unconscious and he's
Yeah.
pulseless.
Well, that's not the way. That's not. I don't want you to think about it being unstable, because cardioversion is for unstable. Pacing is for unstable. It's just this is unstable with a fast heart rate. This is unstable with a slow heart rate. But defibrillation is no heart rate. So
Right.
cardiac arrest is still unstable. All of those are unstable. It's just heartbeat versus no heartbeat. Okay. But because this is only for when they do have a heartbeat, he's in cardiac arrest with no heartbeat. Okay.
Okay, yeah. And so minimize interruptions and compressions. Yes, absolutely.
Because that's that part. Okay.
Resume chest compressions immediately after shock delivery. Yes, because
Okay.
pit crew CPR and defibrillate as soon as possible.
Okay. So in this case, notice how it still came down to the top priorities, right?
Yeah.
The only other thing we would have considered would be IV or IO access for epi if they gave that to us in a list. But for instance, if they use ventilations as part of CPR, then that counts as one of them. So in that case, it would be compressions, ventilations, defib. If they don't, if they just call it CPR, then it's CPR, defib, and IV IO access for epi. Okay. What is this kind of question? This is a put them in order. Okay.
Okay. So this is going to be a one-step question because there really is, that's the whole question.
Okay.
Place the actions in correct order. A patient is found unresponsive, pulseless, and apneic.
So if I put
So
all these three together, what do I call that?
cardiac arrest.
Okay, so I've got a patient in cardiac arrest. So basically, this is asking what are the top priorities in cardiac arrest, which we just said are CPR, defib, and IVIO access for epi. So let's put them in the right order.
Okay, so if we started with D, attach monitor defibrillator and identify the rhythm. I can't really decide where that's going yet, but resume CPR immediately after shock delivery, that's going to be further down. Confirm pulselessness and begin high quality CPR, that's probably going to be 1. So I would say B would be 1. Defibrillate when ready and everyone is clear. Okay, so I would go BD. Oh, yes, BD, AC. B, confirm pulselessness and begin high quality CPR. Yes. D, attach monitor defibrillator and identify the rhythm. Yeah, I guess.
Okay, and that would be correct.
Okay.
So this would be presented as a like a drag and drop scenario. It's just I'm operating from a PDF, so I can't really drag and drop well. But
Right.
yeah, you would just drag and drop them into the correct order on this one. Okay. This next one is it's just multiple choice. Okay.
What is the most appropriate treatment? This is a 2-step. A 72-year-old
Now
patient is
go one line above that. Just go one line above, and look, we're going to try something.
the ECG shows complete AV dissociation. So that's a 3rd
All right.
degree.
Third degree block. So a third degree AV block. What's the immediate treatment for that?
Transcutaneous pacing.
All right. See if we have an answer.
D.
Okay. Now let's read the rest of the story. Let's see if we get the same answer.
Okay, 72-year-old patient is confused, pale, and hypotensive. So he's shocky.
Okay. So the
Uh,
fact that he's shocky, that tells me he's sick and unstable, and we have bradycardia. So if I put all that together, I have symptomatic unstable bradycardia. The answer for that is pacing. Okay. But in this case, they actually described an EKG. They didn't actually show me a picture, but if they had, it would have just shown me a third degree block. But you just want to know these kind of descriptions for EKGs, even when they don't show you one. In this case, third degree block, pacing, transcutaneous pacing. That's our answer. Okay. The
okay.
next one is okay, this is where you're matching okay, so you're matching some kind of electrical situation to these things. So the way you want to approach these is just do one row at a time and
Okay.
say, okay, so VFib, what do we do for VFib?
Defibrillate.
We defib the VFib. Okay. What about
Unstable, regular, narrow, complex attack where the pulse is going to be synchronized cardioversion.
okay?
Symptomatic 3rd degree AV block with hypotension is going to be transcutaneous pacing.
Okay.
Sinus tachycardia caused by hemorrhagic shock is going to be no electrical therapy first.
Okay. Because yeah, we don't typically shock sinus tach.
And then PEA is also going to be no electrical therapy first.
Okay. So that let's say they're in PEA. In addition, so remember, normally it's the priorities for cardiac arrest are high quality CPR, early defibrillation, and then IVIO access for epi. In this case, do we defibrillate if they're in PEA?
No.
There's no defibrillation there. So what else do we do in addition to doing the CPR and the epi?
Identify H's and T's,
Yep.
like reversal
All right. So
clauses.
that's that's it. That's what we're looking for there. Okay, let's go with the next one.
Which medication should the paramedic consider early according to protocol? It's two-step.
Okay.
A dialysis patient has missed 2 treatments. The patient is weak, nauseated, and confused, so he's sick and unstable.
Nice.
BP is 90/50, 2. His pulse is 38, and his respiratory rate is 22. SpO2 of 96%. The ECG shows a wide complex bradycardic rhythm with peaked T waves.
All right. So what are they describing here?
Hyperkalemia.
Okay. What's our treatment for hyperkalemia?
Initials mean calcium chloride.
Okay. Calcium chloride or calcium gluconate. Which one is more potent?
Calcium chloride.
Calcium chloride. Okay. And we already see that in the answer choice. We can just go ahead and pick it. But what are the other treatments for hyperkalemia? So, what are all the treatments?
So it's A, B, C, D, I, K, and that
A, B, C,
is
D's, and then IK. Okay. What's the A?
So that's albuterol.
Nice. How does the albuterol work in this situation?
Is that this the to bring something back into the cell, right? Or vasodilation? Or
Not that
bronchodilation?
part. Okay, so
Bronchodilation.
here's what's happening. These little dots, they're going to represent potassium. So we've got too much potassium inside the blood right now. Originally, the potassium is supposed to, well, the potassium starts off inside the cell at rest, but now, for whatever reason, like let's put a membrane on the outside here. Well, this membrane has gotten damaged.
Mm-hmm.
Okay. So the cell membrane starts to get damaged. Now we've got holes in our borders. So what's happening is some of this potassium is now leaking out and it's getting into the bloodstream. We need it to get back into the cell out of the bloodstream. And how do we do that? Well, we're going to activate the sodium potassium pump. Okay, so this little rectangle here is the sodium potassium pump. Its job is to send sodium. So the sodium starts off on the outside and makes its way on the inside. And then that sodium has to be pumped out through the pump. So it's called sodium potassium because sodium goes out and then potassium goes in. Okay, 3 sodiums go out, 2 potassiums go in. So here, let's do 3 sodium out and then 2 potassium in. That's the job of the pump. We have 2 ways that we can activate the pump. One of them is on the pump, there's what's called a beta 2 receptor. So we can use some kind of beta 2 drug like albuterol to activate the beta 2 receptor, here of the pump that turns the pump on, and now it pumps the potassium back into the cell.
Okay.
Another way to activate the sodium potassium pump is with insulin. So another way to do it is through insulin. Same thing. Turns on the pump, and now it pumps the potassium back into the cell. Okay. So the albuterol and the insulin both turn on the pump. What else do we use?
Bicarb.
Okay. How does that work?
It like negates the acid buildup.
Yes. So what's going to happen is we're going to get more hydrogen inside the cell. And whenever you have too much hydrogen, that's acid. So to counteract all this acid here, we're going to use the bicarb. Okay. The C, of course, is the calcium. How does that work?
Stabilize the cell membrane.
Okay. The calcium is what's going to stabilize the membrane. We're going to kind of clean this up and secure the border again. Okay, that's the calcium. And then what's the D's?
Diuretics, dextrose, and dialysis.
Okay, nice. Diuretics. Diuretics, dextrose, dialysis. Okay. And how does the diuretic work?
So does it filter out?
Well, so that's actually dialysis. Dialysis is going to filter it through a machine. It's going to filter the excess potassium from the blood. The diuretics is going to cause you to just pee off
Urination?
the excess
Yeah.
potassium. And then the K for K-exolate,
Okay,
that's going to be
exfoliate.
given at the hospital. That's going to
So
cause
poop
you
it
to poop
out.
off the excess potassium.
Okay.
And then why do we give the dextrose?
Because you need to give insulin um,
Nice.
for the sodium potassium pump. So you have to give insulin. Do you give dextrose to stabilize the blood sugar?
Yes, exactly. Because insulin is going to drop the blood sugar, so we got to bring it back up with some dextrose. Nice, very good. Does it help to have like this picture of
Y-
hyperkalemia versus just the protocol say to do it?
yeah.
Okay. Was this something that you knew well before me?
No.
Okay. And I really want you guys to always understand the how and the why. So insulin, where does it come from? Who
The
makes it?
pancreas is the
Pancreas.
beta cells. The
Nice.
beta.
It's the pancreatic beta cells of the islets of Langerhans. Okay. The islets of Langerhans make other hormones as well. What are they, and what are the cells that make them?
So glucagon is alpha,
Okay.
and the delta is okay. Hold on. I had it on my head like a second
That
ago.
that's okay. Hey, that's okay. But in that situation, you at least know like two of the three. So the alpha cells make glucagon, the beta cells make the insulin, and the delta cells make somatostatin.
Somatostatin.
Somatostatin. Okay. It's like the emergency brakes. It's like the kill switch for the shut off valve for the body. That and GABA. Okay, let's do another one.
Which treatments may be appropriate according to protocol? Select the two correct answers. Okay. So it's a two-part. A patient has suspected hyperkalemia with wide QRS complexes.
Okay.
Um,
So we got
peak T wave.
hyperkalemia. Give me two treatments for hyperkalemia from this list. Let's start at the bottom.
So it's not going to be adenosine. You wouldn't give adenosine for a wide complex.
Nice.
Aspirin doesn't say anything about chest pain.
Okay.
Nitro, no, he's got poor perfusion, so he's likely hypotensive to start with.
Like it. Nice.
Sodium bicarb and calcium are both part of the ABCDIK. D's
Nice.
IK.
ABCDs IK. Great. Okay. And but you got to know the ABCDs IK to be able to kind of pick the list. But otherwise, even if you didn't know that, we were just able to eliminate down to the answers. All right. This is a matching. When we have these kind of situations, what we want to do is start with the bigger side and
Okay.
just match each one of these. Now, in this case, because you're going to use all of these, it doesn't matter if you start from the bottom, but if you want to start from the bottom, we can. Let's start from the bottom since that's what we're doing normally. Let's just start from the bottom. Bradycardia with complete AV dissociation matches which one of these?
So that is a third degree, so complete heart block.
Okay.
Hypotension and bradycardia with inferior ST elevation is 2,3 AVF. So we're looking at 1. P waves and QRS complexes marching independently. That's a complete heart block. Wide QRS with peaked T waves after missed dialysis is 3. ST elevation in V1 through V4 is going to be anterior. And ST elevation in 2,3 AVF is going to be inferior.
Okay.
So 1.
Good. All right. Now, if we have okay, let's do it a different way. Let's say they tell you you have elevation in leads 2-3 AVF. What's the blood vessel?
RCA,
Primarily the right coronary artery. If we have elevation in V1 through V4, what's the blood vessel?
left anterior descending.
Nice. That's LAD. Okay. Uh, Okay. If we have elevation in 1 AVL V5 V6, what's the blood vessel?
Circumflex?
Uh-huh. 1
Is that
AVL
the
V5
circumflex?
V6, that's going to be lateral, so that's going to be the circumflex artery. Okay, nice. Okay. Um okay, let's do another
Um, what should the paramedic do next according to typical protocols? It's a two-step.
one. Mhm.
A 43-year-old patient has sudden palpitations. The ECG shows a regular narrow complex tach at 188. Patient is alert. BP is 126/78, and vagal maneuvers are unsuccessful.
Okay.
Okay,
So
so
let's
there's,
summarize this. Let's give this a name. What kind of situation is this? Is this
I would
stable
say
or
it's
unstable?
stable.
Okay, because his blood. Okay, he's
They're still
alert
perfusing okay, and they're alert.
and blood pressure is still okay right now. What? Okay, so we're going to call this stable. Now, what would make it unstable?
Altered mental status, hypotension. Okay.
Chest pain, altered mental status, shortness of breath, hypotension. So
Okay.
cash. He, okay, he does have palpitations, but he doesn't really have anything else. Okay, so we're going to say he's stable. And then is he having symptoms or no symptoms?
Symptoms.
He's definitely having symptoms. Actually, let's flop these. Let's call this one symptomatic. And then stable. And is it tachycardia or bradycardia?
Tachycardia.
Okay, so what's our treatment for symptomatic stable tachycardia?
Since vagal maneuvers are not successful, then it would be adenosine.
Okay, so we typically would go vagal, then adenosine, then if that doesn't
Pacemaker.
work, we
Or,
do another adenosine, and then wait, what'd you call it?
yeah, I stopped myself.
Okay.
It would be a synchronized cardioversion.
Yeah, then cardioversion. Okay. Now, what if they're unstable though?
Yeah, it would be an immediate synchronized cardioversion.
Yeah, if they're unstable, we go straight to synchronized cardioversion. Okay, and then we try to get IV access if we can, and pre-medicate them to go ahead and sedate them before we light them up with this electricity. What would be our drug of choice to use for the procedural sedation?
Be Versed,
Okay, so Versed, also known as,
midazolam,
which is a
benzo.
nice. Okay, how does it work?
um,
That's okay. So a benzo increases the frequency of chloride channel openings. Basically, so here's a cell. Remember, everything comes down to the cell. Here's a cell. On a cell, there's a chloride channel. I mean, there are lots of channels: sodium channels, potassium channels, chloride channels, calcium channel. I mean, but in this case, we're talking about the chloride channel. And what we're doing is we're saying we open the channel uh, uh, faster. So when you open a chloride channel, what it does is it takes chloride from the outside of the cell and it now sends it into the cell. But remember, chloride has a negative charge. So when I open the door and I let a lot of chloride rush in, it makes the inside of the cell very negative, and that's what calms down that stops the depolarization, because depolarization is where it's too positive and all kind of craziness is happening. We're going to calm that down by putting a bunch of negative inside, and then that slows down the heart rate. Okay, so it benzos work by increasing the frequency of chloride channel openings, and on the chloride channel there's something called a GABA receptor. So benzos and barbiturates both activate the GABA receptor on the chloride channel. Okay? Benzos and barbiturates both activate the GABA receptor on the chloride channel.
Okay.
And that allows chloride to go into the cell with a negative charge, and it calms down, it slows everything down. The difference in benzos versus barbiturates is benzos increase the frequency of the channel. Barbiturates increase the duration. So I like to say barbiturate. So barbiturates like phenobarbital, secobarbital, barbiturates increase the duration of the channel opening. Both of them still work on the channel. One of them just makes the door open faster. That's benzos.
Okay.
Barbiturates just keep the door open longer. So that's duration. How long it's open versus how fast it opens. They both deal with it opening. Make sense?
Yeah.
Can you teach that back to me?
So the benzo
Mhm.
increases the frequency of the opening of the channel to release chloride
Which
into the
channel?
cell.
Which channel?
The GABA or the
No,
chloride channel
it's going to be the chloride channel, and attached to the chloride channel is the
is GABA.
the GABA receptor. So let me clean that up. So here, let me just get some space so we can do that again. Here's a cell. On the cell, there's a chloride channel. That's how chloride is able to get in or out. Okay? Because remember, all this chloride is on the outside, but we need it to get inside. And the way it has to get inside is it has to go through the channel. We either have to open the door or we got to keep the door
Keep
open
it open.
longer. But either way, it's got to get open. Now, on the chloride channel is a GABA receptor. So this is GABA receptor. And then what attaches to the GABA receptor is GABA. What is GABA? It's an inhibitory neurotransmitter. So it inhibits things. It's a neurotransmitter that slows things down. We also have neurotransmitters that speed things up. That's going to be things like glutamine. In this case, GABA, it calms things down. Because they're having a seizure, things are like amped up in the
Hmm.
brain. We need to calm things down. This is like the other emergency brake of the body. Okay. So we have two ways that we can activate this GABA receptor on this chloride channel. One of them is with a benzo. The other is with a barbiturate.
Barbiturate.
They both activate the same thing, it's just they do it in different ways. The benzos increase the frequency of the channel opening, and the barbiturates increase the duration of the channel opening. Okay?
Yeah.
Does that make a little more sense?
Yeah.
Try it again.
Okay. So the benzo increases the frequency of the calcium channel opening.
Not calcium, chloride.
The chloride channel opening. Um, and the barbiturate increases the duration of the channel opening.
Yes.
So
So
keeping it
one of them just
open.
makes the door open faster. The other just once it's open, it keeps it open longer. Either
Okay.
way, the net result is still the same. Chloride, what because the door
So
once
into
it's
the cell
open, chloride can now go in. So the chloride now goes into the cell and
and
it
slows
makes the
things
cell
down.
very negative. Okay.
Yeah,
Does that make sense?
I think so.
Okay. That's I mean, you may not even get a question like that, but just in case, I want you to kind of understand how the drugs work. Okay, now let's go back to this question. So this question was: we have a stable, symptomatic, stable tachycardia. We already tried a vagal maneuver. Now what's next?
It's me adenosine. It's gonna be
Now
six
it's going to be adenosine.
milligrams.
So that's going to be 6 milligrams adenosine. How do we do it?
Three-way stopcock.
Three-way stop
Rapid
cock
IV
and rapid.
push
Rapid push with a
with a
flush.
flush.
Okay. So about 20 ml flush is what you want to use because we got to really push this all the way and get it to the heart. Why do we have to give it so rapidly?
Is a very short half-life.
Yep. So, and what is the half life of adenosine?
Is it like 6 seconds?
Yeah, like 3 to 5 seconds. It's really fast. How does adenosine work?
Um,
So
that I
it
don't know.
decreases AV nodal
Nodal conduction. Okay,
conduction.
yeah.
That's just a fancy way of saying slows down the heart
On
rate.
the AV
There
node.
are three ways we do that. Three ways we decrease AV nodal conduction or slow down heart rate. And these are our ABCs. The A is adenosine.
Beta blocker and calcium channel blocker.
Yes. Beta blocker, calcium channel blocker. Okay. Beta blockers. How do we recognize beta blockers?
The OLOLs.
The laws, okay, or the laws. How do we recognize calcium channel blockers?
Well, there's two of them, the two
Nice.
classes. So there's
Okay.
the dihydropyridines and the non-dihydropyridines. So
Oh,
that is
nice.
going to
I love it.
be
So we have
the dapines,
di
and
and
then
non-di. Say it
that's
again.
going to be your cardizem, diltiazem, and verapamil.
Okay, I'm sorry. I was talking over you. Say it. Say it again, so I know which is which.
So the dihydropyridines are going to dilate the vessels. That's going to be your like your amlodipine, nicardipine, um,
Nifedipine. Yeah.
the
Okay.
dipines, and then
Dipines. Yes.
the non-dihydropyridines are going to be like your cardizem, diltiazem, verapamil. They like work on
Nice.
the heart themselves.
Very good. I love it.
I've been
I
listening to the
love this.
audio drills. Like, I mean, even laying down on the couch, I have you in my ear. Like,
Oh, I love it. No, I love what I'm hearing. This is amazing. Okay, keep going.
but then I still
So
feel
this
like I'm not ready for the exam.
well, I mean, you like I said, you're probably way more prepared than you think you are. The way
Yeah.
you're answering these questions, I mean, think about it. Like, did you know this same stuff for your last
Mm-mm.
attempt? But you're
No.
just rattling it off with no notes or anything.
Yeah.
That's, I mean, you've definitely put in the work. So I think you're in great shape. Let's keep going.
Which actions are appropriate? So it's plural, it sounds like. Which
Hmm.
actions are
And
appropriate?
they want three. Okay.
Oh, okay, yeah. So select correct choices. It's a two-part, two-step. A patient
Hmm.
has unstable supraventricular tachycardia with altered
All right.
mental status, so they're unstable and
So
sick.
we got unstable tachycardia.
Yes.
Let's get it down to that. I mean, yes, they call this one SVT, right?
Hmm.
But what we need to know is we call it unstable tachycardia, and this altered mental status, chest discomfort, hypotension, that just definitely
All
points
points to
to
unstable.
unstable. These are just symptoms. So what do we do for symptomatic unstable tachycardia? That's how we would approach this.
It's usually a synchronized cardioversion.
Okay, so boom, that
Okay.
has cardioversion in it. And then what
Okay.
else are we going to do? They want three things.
Okay, so start at F.
Okay.
Delay treatment until a full medication history is obtained. Well, that's pointless, but we don't delay anyway. Begin transcutaneous pacing. That's wrong because we're not bradycardic, we're supraventricular, we're tachycardic.
Okay.
Repeat adenosine several times before treating instability. No, because they are already unstable, so you're going to treat it now
Right. And we don't repeat adenosine several times. We only repeat it
twice,
once. But well, we only repeat it once.
and
We
then we
give
keep
it
on
and
med
then repeat it.
control.
Right. But we don't do adenosine when they're unstable. So
Correct.
we got two reasons we would eliminate that. So we've eliminated three. They want three. We're down to three left. So those are the answers. Let's see. Let's see if that works. So
Establish
uh
IV access if it does not delay cardioversion. Yeah, seems
yeah,
reasonable
because
enough.
we're going to need that, especially for sedation, because we're going to probably
Correct.
use that benzo or that barbiturate we were just talking about. That that benzo,
Opens the
of course, again.
the chloride channel or
Say it
keeping it
again.
open. To open the
Say it.
chloride channel or keep it open.
Okay.
Open the
So it's
frequency of
either
the chloride channel.
yeah, it's open it faster. Frequency is fast. So how fast it opens, or we keep it open longer. So frequency of opening or duration of opening. Okay.
Okay.
All right. And then
Support airway and oxygenation as needed. Yeah, because they are experiencing altered mental status. They could possibly be hypoxic due to increased cardiac output due to the rapid
okay,
heart rate.
okay, sure. Well, and it's actually going to decrease their cardiac output just because of their stroke. Their heart rate goes up,
Stroke
their
volume.
stroke
That's what I was
volume
looking
goes
for.
down.
Yeah.
Okay. And then prepare for synchronized cardioversion. So yeah, we kind of eliminate it down to the three. Let's skip ahead to some other ones. Just so we okay. This is where it's a farm question where you're just matching the drug to the situation. So
Okay.
they're going to just start one row at a time. When
So classify each medication by the emergency. Okay. So atropine is going to go into bradycardia. Adenosine is going to go into tachycardia. Aspirin is going into ACS. Calcium chloride gluconate is going to go into hyperkalemia, and a benzo into seizure.
Okay, let's talk about them. Atropine, how does it work? Or what's its
It is
class?
a muscarinic antagonist, anticholinergic. Uh,
Anti-parasympathetic. Nice.
that.
All right, give me two.
And it dries secretions, or it dries.
Okay, that's the muscarinic antagonist part where it's going to dry secretions. What's a situation where we have secretions where we need to use atropine?
Is going to be organophosphate.
Organophosphate. Okay, so in organophosphate poisoning, we're going to use atropine plus what?
2-PAM.
2-PAM. 2-PAM is also known as
Don't know.
pralidoxine. I'll show it to you. It's pralidoxine. But anyway, okay, so that's atropine. How does adenosine work again? It's one of our
Um,
ABCs that do what?
it slows down the AV nodal conduction
Slows down
and
AV
slows
nodal
down the heart
conduction,
rate.
and that's kind of how you're looking for it. Okay, aspirin. How does it work?
Irreversibly binds to COX-1 and COX-2, and that is
Love
a
it.
for us it's an antiplatelet aggregator.
Nice. Okay, there are three other indications of aspirin. What are they?
Antipyretic.
You need to be the model. You're the model student. I need you on all the videos.
I'm trying.
You're doing great.
Antipyretic, anti-inflammatory, and uh,
Analgesic for
pain
pain.
management.
Nice. Very nice. Okay. Calcium chloride, calcium gluconate. How does it work?
Stabilizes the cell membrane.
Okay, and we're gonna stabilize that cell membrane in the setting of hyperkalemia. It's one of the first things that you're going to give, especially if you suspect hyperkalemia or you have changes in your EKG. Now, what are the changes in the EKG associated with hyperkalemia?
Peak T waves,
Okay.
prolonged QRS
Mm-hmm.
duration,
Mm-hmm.
and a
Increased
prolonged
PR interval.
PR interval.
So when you increase the PR interval, it stretches it out. That slows down the heart rate. When you prolong the QRS, that stretches it out, slows down the heart rate. This is why if you give too much potassium, I mean, I'm sorry. This is why if their potassium is too high, it can slow down the heart rate to zero. Okay, and this is also why they give potassium as one of the cocktail in lethal injection to purposely slow down the heart rate, i.e., kill the person. Okay, and then benzos again.
That increases uh, the chloride
So
channel
it's
opening
okay. Both of them deal with the channel opening. It's just, do you open it quickly or do you keep it
quickly
open longer? So the two words are going to be frequency
and duration.
and duration. So think of like barbituration. Barbituration.
I
Okay.
can figure out when goes where, but I just
Okay. No problem. That's okay. But that's because I want you to, you never know with when it comes to medications, you never know what's going to be asked. So you want to know, like, yes, you want to know. So in this case, these are all indications, but you also want to know contraindications. You want to know, like, for instance, hyperkalemia. So hyperkalemia, yes, it can happen for somebody who's missed dialysis. There are lots of things that can cause somebody's potassium to go up. First of all, what is a normal potassium level?
is it 5?
So it's going to be 3.5 to 5. Okay. So that's normal. So excess potassium or hyperkalemia is once it's greater than 5.0. What are some situations that can cause excess potassium in the blood?
Um, well, obviously hyperkalemia. Is there would it be like overdoses?
Uh, it it could, if there's some kind of acid-base disturbance associated with that overdose, sure. But some things I want you to think of are going to be like crush injury, compartment syndrome, rhabdo,
Okay.
tumor lysis syndrome, cancer treatments, burns. Okay, so these are or sepsis. So these are things that can be associated, or DKA. These are all things that can be associated with hyperkalemia. Okay, so it's kind of a long list, right? So
Right.
it's not so much that you just know the whole list, but these are things to consider. Where else does this have implications? It comes to airway management. So there's a certain paralytic that you would not want to give if this patient has hyperkalemia. So if they
That's
have burns,
succinylcholine.
sepsis, decay, all right, that's going to be succinylcholine. Succinylcholine, how does it work?
That I don't know.
Okay, so it's a paralytic, and when it comes to paralytics, you have
Oh, it's
two
increased the
flavors of them.
fasciculations.
It does. So fasciculations is where the muscles just
Like,
start. You have this tremor. You have all this activity in the muscles suddenly. Okay. Uh, Paralytics are either what are called depolarizing agents or non-depolarizing agents. The depolarizing one is SUX, and that's the one that causes all the fasciculations, all the tremors. The non-depolarizing agents are going to be ROC, so rocuronium, vecuronium. Okay. The one that we're really concerned with is the SUX because of the depolarizations and the fasciculations. What else can, so SUX would be contraindicated if they have hyperkalemia, but what else can SUX cause when you start activating all these muscles and you start all this tremor activity? It heats up the body.
lactic
So what?
acid.
More specifically, it causes something called malignant hyperthermia. This is where your body temperature gets dangerously hot and can kind of send you into a heat stroke. So there's an antidote that we have, and this is why SUX gets tested sometimes, is because of the antidote. What is the antidote for SUX if it causes this malignant hyperthermia? You know this? That's going to be dantrolene. Dantrolene. Okay.
Okay.
So antidote for SUX is dantrolene. Why do you give it? Is because we're concerned that SUX can cause malignant hyperthermia, where their body temperature gets too hot because of all these muscles. Think about muscles in the whole body getting activated at the same time, from the eyelids down to the toe. Okay, so the body heats up, and that can cause a lot of problems. All right, good. That's a good review of that one. Let's go to the next one.
What should the paramedic do first? It's a two-step. You
Mhm.
arrive at a chemical plant, so I'm thinking safety at this point. For a
Nice.
patient down near a leaking tank, even more safety.
Okay.
Several workers are coughing. So for sure, safety MCI situation and
Okay.
tearing. So it's organophosphate, it sounds like.
Ooh. Okay.
A supervisor yells that the area may contain chlorine gas.
Okay.
Okay.
So,
Um,
based on
so I'm
everything you said, go find that answer.
begin triage in the contaminated area before no, because we only go in the cold zone. If anything,
Nice.
send one crew member in without PPE. That's a dumb answer.
Okay.
We wouldn't do that unless you hate them. But stage uphill and upwind. Request hazmat resources and avoid entry until yes, that's seen as safe. Yeah, that wouldn't be the answer. Enter
Okay.
quickly with a bag, valve, mask, and remove the closest patient. No.
No, everything you said was about safety, which is the first point of the 5-star medic method. Is there a safety concern? In this case, yes, there is. So, and then yes, we stage uphill and upwind. Okay. So that was a EMS operations kind of question. That's another one. These are more EMS operations. Let's skip ahead a little. Let's try this one.
What is the best action? Okay. So two-step, a paramedic
Mhm.
administers fentanyl for a painful femur fracture. During restocking, a crew realizes the controlled substance documentation is incomplete. Okay. So we don't want to replace the vial later without recording the discrepancy because that's a narcotic violation.
Okay.
Ask the patient to sign a medication log after arrival. No, the patient doesn't generally sign the medication log. Complete documentation according to agency policy and notify the appropriate supervisor or controlled substance process. Yes. Ignore it because the medication was clinically indicated. No, because you have to track all of your narcotics.
Okay. Next.
Select the 3 correct answers. Is it 2-step? During ambulance checkout, which findings should be corrected before the unit is placed in service?
Okay. So before the way you want to think of this is before I go on another call, what must I do in order to be able to go on another call? So give me 3. Let's start with the bottom.
Oxygen cylinder below required minimum. I would say no.
Why?
Because like you still have multiple spare tanks. You should have multiple spare tanks.
Nice. Okay, good.
Completed PCRs from previous calls. Generally yes, but I don't think so for this situation.
Yeah,
You can still go on another call.
Would this be an absolute reason that you cannot take another call?
No.
No.
Extra clean blankets in the cabinet. No.
Yeah, because if we don't have, sometimes we don't even have a sheet.
Yeah. Expired epi in the medication kit. Yes.
We got to have that.
Monitor defibrillator battery not charged. You need that, even though you do have backups, but you do need that.
Yeah, you got to have a monitor that works.
And then missing pediatric BVM, you absolutely need that.
We absolutely need that. Okay, so we just kind of eliminate it down to the right answers. Notice the strategy if we just keep eliminating down to the right answer, right? We eliminate what we know is obviously wrong, even when we don't know if something is right. Just eliminate what's wrong. Okay, let's go to the next one.
What should the paramedic do first? It's a 2-step. 24-year-old patient is apneic after suspected opioid overdose.
Okay, stop right there. Apneic.
So it's a ventilation problem.
Okay, now, right now that this tells me they're not breathing, what's the next question I have?
Does they have a pulse?
Pulse. Okay, and do they in this case? Yes or no? Pulse or no?
Strong carotid pulse is present. So we don't do
Okay,
CPR, but
what do I describe this situation as?
Respiratory arrest.
Okay, so this is, let's do it in purple. This is respiratory arrest, which is what type of problem?
Ventilation.
This is a ventilation problem. What's the fix for it?
BVM with an OPA, NPA, or an oxygen.
Okay, BVM, airway adjunct, and O2. Got it. All right, so find my answer.
B, begin positive pressure ventilation with high flow oxygen.
Because this is a ventilation problem. It's respiratory arrest, a ventilation problem. See, all they did is they just gave us a scenario. They put an age in there, but we got this down to respiratory arrest which is ventilation. They could have added a whole bunch of details, made the paragraph like 2 pages long. It still came down to this. Make sense? Because what if they just said, instead of saying opiate overdose, they call it alcohol poisoning? What if they call it neuromuscular disorder, myasthenia gravis? What if they call it, what if they say heparin, codeine? What if they say benzo? It doesn't matter. Those are just
They're still
details.
apneic.
Yeah, that's what we need to get it down to. This is an apneic patient that's respiratory arrest with a ventilation problem. The fix for that is BVM. Okay, let's go to the next one.
Select the 3 correct answers. So it's 2-step. A patient has suspected opioid overdose with respirations of 4 minutes. So it's inadequate. Cyanosis and a pulse. So they're a ventilation problem.
Okay,
Which
so
actions
there
are
again,
appropriate?
this is not respiratory arrest, but what do I call this one?
Respiratory failure.
This is respiratory failure. It's still a BVM problem. I mean, a ventilation problem with a BVM. So, find my answer.
You need 3. So ignore ventilation because naloxone reverses opioids. No, because it's not your first step. That's too advanced or too expensive.
Nice.
Begin CPR despite a definitive pulse. No, because they have a pulse. Delay ventilation until naloxone takes effect. No, because that's a delay and we're still not technically indicated yet. Administer naloxone according to protocol. Sure. Ventilate with the BVM and oxygen, yes, and open and maintain the airway, yes.
Okay. But notice this literally comes down to, okay, so this is the BVM part, right? There's your BVM part. We also use O2 with the BVM. There's your oxygen. And then when we do the adjunct, that's helping to open and
The
maintain the
airway,
airway, right?
keeping
It
it
literally
open.
just came straight, it just came straight off of this. They just kind of put it in the form of answer choices. That's why knowing the foundational information is always like most important. When I know the content well and I understand, like when I understand the patho of everything well, all questions are easier than when I don't understand, right?
Well, I think that's like my problem because I feel like all this stuff is easy, but like then I sit in the exam and I'm like, this is so hard.
Well,
At least the last 2 times.
but you're going to do exactly what you're doing today. And if you do exactly what you're doing today, you're going to pass this test.
I need to.
Okay. Just do exactly what you're doing today and you're going to pass this test, and you're going to send me a message saying, Coach, I passed.
Yeah.
And I'm going to announce you in the community Saturday, right?
I test Saturday early in the morning, 10:30.
Nice. Okay. Saturday, you're going to send me a message that afternoon saying, Coach, I passed, with a screenshot of the congratulations email. And I'm telling you, Maris, you're in great shape if you'll just do exactly what you're doing today. What I want you to do is I want you to just slow down. Just really slow down and ask yourself, like, you've got plenty of time. You don't worry about the time clock at all. I want you to just slow down and say, what's the question asking? We're going to start with the question itself so I know what is the question. Is it a one step or two step, just like we're doing? All right. If it's a two step, I need a story. As I'm reading the story, I want you to analyzing exactly like you're doing today. You're doing it already. You're analyzing, saying, okay, sick or not sick, safety concern, stable, not stable. And then I want you to, now the other thing I want you to do is just go one step further and kind of take all that information and summarize it. You notice how I keep kind of reducing it down to stable or symptomatic stable bradycardia, symptomatic stable tachycardia, cardiac arrest, respiratory failure, right?
Yeah.
I take all these details and I'm just reducing it down to like something manageable. And then I say, well, what do you do for this thing? Oh, symptomatic stable bradycardia. Oh, that's atropine. Symptomatic unstable bradycardia, that's pacing. Symptomatic stable tachycardia, that's vagal maneuver, then adenosine. Symptomatic unstable tachycardia, that's synchronized cardioversion. Cardiac arrest, CPR, defibrillation, IVIO access for epi. And I notice I keep reducing all this fluff down to just something very manageable. And then I say, what do you do for this? Does that make
Yeah.
sense?
Yeah.
And I'm not doing anything magical. It's just I have a process that I follow with every single question. Now, obviously, sometimes they're just going to ask you some random question like, what's the mechanism of aspirin? Well, I don't need a process for that. I just need to know the answer. But otherwise, I just follow this system over and over and over again, question after question. Now, let's fast forward to, let's go to, okay, here we go. Let's do this one.
What treatment should the paramedic anticipate? It's a
Okay.
two-step. A farm worker, I'm already thinking organophosphates as a
Nice.
farm worker is confused and dyspneic after pesticide exposure. Okay, so I'm thinking safety, but I'm definitely thinking that this is organophosphate.
Okay.
The patient has vomiting, diarrhea, so we have the sludgem symptoms.
Okay.
Pinpoint pupils and excessive salivation and bronchorrhea.
Okay. So yeah,
What
we got this.
what treatment
That
should
all
the
matches.
paramedic anticipate?
Okay.
It's going to be B, atropine and pralidoxime.
Pralidoxime. That's the 2-PAM.
Yeah.
Okay. So atropine and the 2-PAM. So and then the other thing that we also need to consider though is because this can this can still be It can cause a oxygenation problem, a ventilation problem, and or perfusion problem. It's got to be one of the three, right? Because all problems come down to those things. So we still need to be, we still have to make sure they're oxygenating well. We still have to make sure they're ventilating well. We may have to use a BVM, especially if it actually decreases their respiratory drive, because this is some kind of nerve agent that, so you think organophosphates, the reason they're so deadly is it's affecting a nerve. So here's your nerve, and this nerve is going to innervate a muscle. Well, this big muscle could be the diaphragm that causes you to breathe. So it could affect the phrenic nerve that affects the diaphragm. Okay. That's what would cause you to go into respiratory failure, is the nerve gets damaged. And now your diaphragm doesn't get powered up. So you can't breathe. By the way, when you breathe in, which way does the diaphragm move? So the diaphragm is normally at this position in rest, but when you take a deep breath, which way does the diaphragm move?
Up, upward.
So it actually goes down. So at first, so here's your patient. Okay? First, the diaphragm is kind of in this kind of position. That's the rest position. But then once you take a deep breath, the diaphragm goes down and it moves it to this position. What that does is it frees up, it opens up more space. So when this diaphragm goes down to here, now you have a lot more, because right now you only have this much space in your lungs. But once this diaphragm contracts and goes down, you have this much space in your lungs. Make sense?
Yeah.
So it goes down to give you more space. And then when you breathe out, it goes back up. So when you breathe in, it goes down. When you breathe out, it goes back up. Okay? When it comes to respiration, so when it comes to respiration, or let's say ventilation, when you inhale, is that active or passive?
Active.
When you inhale, that's active. It takes work to breathe in, and then you just passively push the air out, or just kind of think of a balloon. It takes work to blow up the balloon, but it does not take any work at all to just let it go. Okay. All right. Cool. Let's go to the next one.
Which actions are appropriate? Select the 3 correct answers. Two-step then? A patient has suspected organophosphate exposure with excessive secretions and respiratory distress. Okay.
Start at the bottom.
We're not giving nitro for bradycardia. The story says nothing about it, and we're not giving nitro for bradycardia anyway. Transport without notifying the receiving facility of contamination, that's a no-no. Delay airway support until antidotes work. No, we're not delaying anything. Administer atropine and pralidoxime according to protocol, yes. Support airway ventilation, yes. And ensure responder safety. Consider decontamination, yes.
Okay. So we just kind of eliminate to the right answer. Okay. What questions do you have?
I guess I have some hard times, I think, when it comes down to some operation questions, like incident commander or medical branch officer.
Okay.
And then
all right. So what okay, when it comes to the incident command system structure, the very first person at the top is the incident commander. Okay. Now there are 3 kind of like quote unquote assistants or that are part of the incident management team. Okay. And do you know what those are? So you got we always
safety
have
officer.
to have okay. So safety officer is going to be one of them. We all,
medical,
that's a safety concern. Say it again.
Medical officer, medical branch officer.
Not necessarily. Well, I mean, so this is just general for any kind of situation. You only have like a medical if it's like a medical kind of call. I mean, obviously for EMS that makes sense, but
is there logistics?
Logistics is a different. It's a section. So it's going to be a safety officer, you're going to have a liaison officer, and then you're going to have a public information officer. Those are a
Okay.
part of, so these four, now you must have an incident commander, always. These other three things, so this four pack here is kind of like the incident management team. So incident commander, safety officer, liaison officer, public information officer. Under that, you're going to have what are called sections. Okay. And they're
Mm-hmm.
typically four sections. And these sections are kind of, the leader of that section is called the section chief. Okay. And
Yeah.
the four sections, you're going to have a operations section. You'll typically have a planning section. You're going to have a finance, like finance and admin, and then logistics. Okay. And those
Mm-hmm.
are typically your sections. And the leader of those is called a section chief. And then it gets down into what are called branches. So then you have branches. So you may have like an operations branch or EMS branch or whatever. And those branches, or the leader of that is called a director. So you have a branch director. Okay. If you ever get an opportunity, or I don't know if you have, if you ever get an opportunity to do like contracting work and you get to be one of these, it's great. I'll just tell you this. When I first got to Chicago, so I left Orlando and I got on a project with COVID. I was a liaison officer. It paid $90 an hour to like do 3 reports a day.
Mm.
That adds up very quickly.
Yeah.
Multi 6-figure income in just a matter of a few months. It allowed me to be able to travel the world and become a pilot and all this cool stuff. But those contracts, it pay way different than regular ground paramedic pay. Okay. Now, being a safety officer, you can take a, this has nothing to do with our class right now, but this is just information for you to know. You could take a OSHA 30 class, um, 30 hours, 1 week. Do it online. Go to OSHA360.com or whatever. Get your safety officer credential, or get your OSHA 30 certification to be a safety officer. All these like big projects, where big project management situations, they all have to have a safety officer. Sometimes you're just checking fire extinguishers, making sure the AED is in compliance, stuff like that. We've had people get paid like $75 an hour for some of these projects for
It's crazy.
months or a year to like walk around with a hard hat on and a clipboard and check stuff, right? But you being a paramedic, having a supervisor experience, will definitely kind of help you get into these positions. And then what you want to do is just start taking these additional FEMA courses. So everybody has to have your ICS 100, 200, no, what?
700, I think.
Yeah,
One.
100, 200, 700, and 800. And then if you can get the 300 and 400 series, that would be great as well for the supervisory management type positions. But what you want to look up for is something called a position task book. Just Google it, position task book. And so each of these positions has a task book that you can complete, and it'll tell you like all step by step, what do you need to do? And it basically just kind of certifies you that you have the experience and the knowledge to be this type of position. And you could start, like, for instance, I've been a liaison officer, I've been a branch director, and I've been a section chief. I've never been an incident commander, but I've been several things. And the more of that you can kind of add to your resume, it just opens all kinds of doors. I'm telling you, natural disasters happen all the time,
Mhm.
and this is big money, like big money.
Yeah.
So get into that as quickly as you can. All right.
My other thing would be like the placards, like on the backs of trucks, as far as what's flammable gas or like
Okay.
that.
Now that you're just gonna have to review. I'm not a I'm not an expert in that in hazmat. The big thing there is not so much that you have to be an expert. It's just you have to have awareness of it. So the some things that could come up in a test question is like, okay, how would you recognize the placard? Well, number one, you don't want to be so close that you can just see it. You want to be so far away that you need binoculars to see it, right? Because that's going to keep you far away from the contaminants. So binoculars, you want to be able to use binoculars to see the placard. Now, when you see the placard, so there's going to be a pictogram that with some kind of symbol, where do you find out what that symbol means? You're going to look in the big orange
the
book.
erg book, right?
Yeah, right. The emergency response guidebook. Um, that kind of stuff, a lot of that just kind of comes down to just it's common sense stuff, or you just need to know where to find the information. You don't necessarily need to know what all of it means. Um, if you get a question like that, you either know it or not, but remember, you don't have to know everything to pass. I'm telling you, based on what I've seen today, if you'll just follow the steps, you're going to do well. Like your information is solid, your recall is solid, your reasoning makes sense in terms of like, oh no, there's several times you're like, no, we're not going to do this because of whatever. That reasoning is what's going to help you keep making safe decisions. I feel very strongly that you're going to do well as long as you follow the steps. Now, if you go just do your own thing, I don't know. But if you
Right.
follow the steps, I think you're going to do very well. Don't overthink it at all. Now, let's shift gears a little bit. So, inside of our school community, let me get my screen pulled up. Okay, so let's go to classroom. All right, so right here under the 14 days program, if we go to final week before exam, so you are Thursday, Friday, Saturday, you're 3 days away, right?
Yeah.
Okay, so you would just go to 3 days away. I think you already did
I did
these.
all of that already. Like this is what I just pulled up. I'm like all the way.
Okay,
So
and you did these 100 questions.
I did those last night, and I
Okay,
got
well,
a
you're
97
already
on that.
ahead. So one thing I do, so in fact, for you, if you want to, um, if you want to focus on just one thing, like if time is like at this point, don't worry about doing any more videos. I think you're solid. What I would have you do is just go to classroom, go to bonus resources, comprehensive study guide, and just go through the study guide. Just kind of say, okay, do I know this or do I not? Because some of the things you may have like learned about it earlier in a cohort or something, but just go through this comprehensive study guide and just kind of quiz yourself to see, do I understand this or not? There's a whole here. Let's just pull it up. There's a whole section on okay, so like for here, make sure you know the buckets in order, the 5 buckets. um let's see, like a lot of this stuff, this is just basic stuff that came up in the NREMT past study course about, opening the airway, head tilt, chin lift, jaw thrust. Like those are simple things, but you still have to remember the basics. Okay, suction time for an adult versus kid, contraindications for OPA versus NPA, things like that. Um, like this is just normal basic stuff. Okay, we already talked about organophosphate poisoning and sludge M. Just know like what all the letters mean. Like the M is meiosis for pinpoint pupils. We see that with organophosphates. We also see that with opiates. Those are the top two that we are concerned with. It's a lot of other things, but the main two are those two. BFAST, what does that apply to?
Stroke.
It's going to be a stroke. Okay. And you just want to use this as like a quick, okay, do I remember OPQRST or OPQRSTI? Okay.
That comes in your secondary.
That's a part of your secondary survey. Physical exam, we either do a full head to toe or we do a focused. Uh, let's see, I don't know, it should say it in there, but for major trauma and unresponsive, we do a full head to toe. Otherwise, we do a focus exam. So I've got some stuff on the abdominal quadrants or the 9 abdominal regions. Like this is stuff where it's just like you got to know it kind of thing. Care sign. Okay, care sign is where you have splenic laceration with pain to the left shoulder. Murphy sign, on the other hand, is where you have either a liver or gallbladder problem, primarily with pain toward the right shoulder. Okay, so that's
Mm-hmm.
Kerr sign, Murphy sign. And then, of course, when it comes to bruising, we have like Cullen's, Gray Turner, and things like that. But yeah, but what I would do is just kind of go through this. Like I said, there's so much information in this in this study guide. This would
Yeah.
be just a good thing to review just to make sure, hey, I got it. If you can confidently answer nearly every one of these questions, you're going to pass this test 100%. Because that's the content. I mean, that's where the content is coming from.
Right.
All I've done is taken like a book and just condense it down to like the high yield information. Now, do I cover everything possible that you would ever want to know? No, no book, no one book even does that. The books would need to be like, as high as the building. So, but the thing is, you don't have to know everything. You have to know what to do when you don't know everything, and that's
Yeah.
follow a system. Just follow the same system. Some things that you want to draw out on your page actually come down to, let's see.
I figured I would probably draw the 5-star. I would write out the seed tricks. I would write out, well, the oxygen ventilation, all the triangles, Mr. Ladd,
Yep.
and the 5 buckets I would probably try to do.
Okay. So exactly that. So we're going to go to if you'll go to in the bonus resources, the 5-star drawing study guide, it's going to be, so this is the whole thing about the seed tricks. There are your
Mm-hmm.
5 buckets. Okay, this is your 5 buckets. And then this. So this one page is like what I would know cold. Here's your 5-star medic method. We've got the trauma triad of death, the pediatric assessment triangle, Cushing's triad, and Beck's triad. And then, of course, our main triangle is oxygenation, ventilation, perfusion. So we've got 5 triangles. And then Mr. Ladd, let's see. You know Mr. Ladd, right?
Yeah.
All right, so Mr. Ladd right here.
Now,
What other
asthma is
questions?
normally a ventilation problem, right? Asthma is usually ventilation, CO2 out.
Okay, so asthma can be both because, like, if it can be, when I say both, it can be oxygenation and ventilation.
Mm.
Because if you have mucus in your airway, for instance, it's going to affect oxygen coming in because there's something in the way, and it's going to affect CO2 going out because there's something in the way. So it's both. But the thing with a lot of these oxygenation ventilation is there's so much overlap. So just know it as it's both. But yes, eventually it's going to lead to respiratory failure, which is primarily a ventilation problem.
Now, when I sit in my test, when they assign me to my computer and I go in, the last time I went there, they did not give me a laminated page. They gave me just a white piece of computer paper. And I asked them if I could get more, and they were like, you have to come back out for every individual sheet.
Oh, gosh. Okay.
Like when I sit down there, before I click even the 10-minute guide, can I just write all that stuff down before I even start the guide? Like the instructions?
I would just double check with them to make sure they're okay with that. But they may have it to where, like, once you start the tutorial, of course the clock starts going at that point. But you've already taken the test, you kind of know how the test works, so you don't necessarily have to spend the whole time like watching the tutorial. You can use that time to be jotting down your notes. Whether you can do it before the tutorial or not is a question that I would ask them in the thing. Like once you get in the test center, say, hey, can I just jot down some notes, and let them tell you, because you don't want to have any kind of test center violation. So just double check with the test center just to make sure you're following all their rules.
Okay.
But do take like 5 minutes though, and kind of jot down like your 5 triangles, Mr. Ladd, your seed tricks. Just kind of jot that down, and then just trust the process and follow the steps.
Yeah.
Maris, your knowledge. So, if you needed me to say it, your knowledge is strong. Your clinical judgment is strong. You're in a great position to pass the test. If I felt that you were not, I would say, Maris, you're not ready. But I'm telling you, Maris, you are ready to test.
Okay. Thank you.
Okay. Yeah, you're ready, and just cut yourself some slack. You've done the work. You've prepared. Over these next few days, just kind of go through the comprehensive study guide just to say, okay, do I know this? Do I not know it? If you want to listen to the audio drills again, if you have time, that's fine. If not, don't worry about it. You've done enough. You've probably done more than enough at this point. So I think you're going to be fine.
Okay. I hope so.
I think you're going to be fine. And I just need you to believe in yourself. And then when you go to the go to so we're going to go back to classroom, the 14 days, final day, final week before, go to the day before. So on Friday, I want you to make sure you do this.
Okay.
Okay. Make sure you read this this part at the end. Make sure you read that again the night before. Also, practice drawing out all the stuff that you're going to use on your little laminated sheet or computer paper, whatever they give you. Practice doing that beforehand so that it's not your first time doing it on the test. Like
Yeah.
literally practice drawing it out like 5 times so that you're real quick with it, so that you're not wasting time. You're as calm as possible. If during the exam at any point you feel yourself just getting worked up, just take 30 seconds and do some box breathing. So are you familiar with that?
Yeah.
Okay. So breathe. So just think of a box, four
You breathe
sides of
in
a
for
box.
4, pause, breathe out for 4, right?
Yes. So in for 4, hold for 4, out for 4, hold for
Hold for
4.
4.
In, hold, out, hold. 4 seconds each. Do that a few times. Do that 4 or 5 times. It just kind of really activates your parasympathetic nervous system, calms you down, floods your brain with oxygen when you're taking really deep breaths like that, and kind of gets you a little more focused. Um, have a good night's rest. The morning of, try to have some breakfast, something kind of light, with some protein. You don't want anything. You don't want like too heavy on the carbs. That's going to make you tired and you know take so much energy to digest. So a good protein source, some eggs or egg whites or whatever you would normally use, a protein shake or something like that, or a protein bar. Nothing too heavy. Don't overdo it with the caffeine, and don't have too many liquids that you got to pee during the exam because it stresses you out.
Yeah.
You've got plenty of time. You got more than enough time. So what's going to happen is as you're going through, just follow the steps. Um, you'll be able to. So in the on your screen, you can press this little button to make the question number go away. There's also this clock button that you can
Make
press
time go
to
away.
either show the time or not show the time. Uh, it's a good idea to at least know the time. Don't obsess over it though. But if the if knowing the question number affects you, just get rid of it. Just hide it. Okay. And then eventually, what's going to happen? So what's going to happen eventually is this. You're going to go through question after question after question. Boom, you're on this question. All right. If you feel like the questions are getting harder, great. That's a wonderful sign. It means that the computer is adapting to kind of figure out, once it has a 95% confidence that Maris knows her stuff, the next thing that happens is the screen just goes to this.
Yeah.
It
And that
just
can happen
blinks
at
out.
110, right?
Say that
For the
again.
medic. It can happen at 110 for the medic.
110 is the minimum, 150 is the max.
I hit
So,
150 both times. The last
okay,
2 times was 150.
that's okay.
So
And even, I mean, you could pass at 150, you could pass at 110. But in this case, probably what'll happen is at 110, don't worry about the number. No matter what number it is, eventually this is going to happen. The screen is going to blink out. And then the next thing that's going to happen is you're just going to walk out of that exam center telling yourself, I did it the whole time, just remembering I did this. And then the next thing that happens is 30 minutes to an hour later, that's what happens.
Hopefully, yeah.
Not hopefully. Yes,
Yeah,
that's
it's
well,
just
this is your
it's
moment. And I need you to believe in yourself. Maris, I 100% believe in you. I'm telling
thank
you,
you.
you can do this. You have what it takes. This is your moment. I just need you to see it for yourself. You've done the work. Now, if you had not done the work, that'd be a different story. But because you've done the work, you've put in the time, you've shown up, you've played full out, you've asked me questions. We're doing a session today. You've done
Mm.
the work. Now it's just a matter of you just have to go execute the exam. Don't stress out about the exam. You're going to be fine. Um, and then I look forward to congratulating you Saturday. Okay.
Thank you so
All right.
much.
So, how's this experience been with you overall?
Great. I can't thank you enough, even before taking the test. You've got a mastered program. I haven't learned easily really at all. I've been out of school for a long time, and I like this just kind of brought this everything that you do clicks because you have something that goes to every teaching, um, every way people learn.
Okay.
So you have audio, you have visual, you have engagement, you have like all of that. So for me, I've used all of that. I have a hearing issue, so I wear hearing aids, and so for me,
Oh,
I'm more of a visual, and so that helps me. But like I said, even when I'm laying on the couch, even when I'm sleeping, I've had one headphone in at work, and I fall asleep to your voice. It's
oh,
weird,
wow.
I know, but I like I can say that everything as I'm going, and my subconscious is still answering questions like as I'm resting on the couch, and I still feel myself because I'm not in a deep like anything. But I've listened to it in the
Okay.
car. My son is answering questions. He's 5, and he's answering questions. I mean, I'm like, sorry, buddy, but until we take this test, like, this is what we're listening to. We're not listening to songs. We're listening to this. And,
Oh,
it's,
wow.
I think that it's been good. I've really enjoyed it. And I'm going to go into the EKG mastery next time.
Okay.
Once everything for this is all done.
Sure.
But
Well, I hope you feel that this experience was worth it. I remember our initial conversation,
yeah,
and sometimes it's hard to quantify all of this stuff in like a Facebook post, right? And it's one of these things where I have to say like you just got to trust me on this. Like once you're in the program, you're going to see a difference, and I
yeah,
hope you feel that you've seen the difference.
like 90% of the stuff seems easy now. Like questions seem easy, but that's where I feel like maybe I'm just like, maybe this isn't, that's why I keep asking, like, is this
But it's
comparable? Is this
supposed
really,
to get easier as you get better.
yeah. So I'm like, maybe I'm just, I don't know, maybe I'm just doing better, or maybe I don't know.
You are
Um,
doing better.
I hope so.
Which is
I
the
think
goal,
so.
though. I mean, that's what's supposed to happen. So don't beat yourself up on that. You're exactly where you should be. Um, would you say that? So you definitely feel that this was worth it.
Absolutely.
Okay.
I wouldn't even think twice next time. And like I've seen you posting in other people's groups like on Facebook, and I've been
Uh huh.
like, no, this is the program you need to be on. Like
Okay.
I may have tagged you once or twice, but I'm like, this is where you need to be. And I've now followed you on TikTok. I've followed you on Facebook. I've like been
Okay.
on all of the platforms trying to just like amp it up because I believe in the program. Like the work that you put into the program is insane.
What is the difference that you've noticed compared to other programs that you've seen or used?
Well, from the get-go, I was doing medic tests because that's what helped me pass my state exam
Hmm.
like 15 years ago or
Mm-hmm.
whatever it was, 12 years ago. That helped me pass my state exam. And I was rocking all of the National Registry simulators. Like even before my last attempt, I was a 1483 out of 1500.
Hmm.
And I never once failed a single mock exam. And then I
Mm-hmm.
signed up after that first attempt, I signed up for pre-hospital prep,
Mm-hmm.
and was working on that one. And I'd never heard of your program before that. Before you reached out to
Sure.
me, I'd never heard of it.
Mm-hmm.
And then so I just did all these like self-teaching, self-examination programs and never once did badly on them. But then I'd go sit for the exam and we know where we end up.
What's the difference in how I teach compared to the other programs?
Well, there is no teaching in the other programs. There really isn't.
Oh, oh, okay.
So 90% of the time there really isn't. It's just like like they have an AI thing that will kind of just see where you struggle. But
Mm-hmm.
like I said, for you, you have all like you hit something out of every box as far as like verbal,
Mm-hmm.
visual, audio.
Mm-hmm.
Even if there was no words, like if somebody was deaf, you can look at your 5 drawings and be like, okay, this. Or if you wanted the audio,
Mm,
if you're an audio learner, you can put it on a heart speaker and you play it all day
mhm.
long. Or like, so you have videos that are interactive, which is why I kept asking you, like, hey, can we go live? Can we go live? Because I like really enjoy this like
Okay.
interaction.
Have you found that learning has been more fun?
Absolutely. It kind of
Okay.
brought me back because I keep saying to myself, like, I want to go to NP school or I want to go to PA school. I'm sitting here and I'm like, I don't know if I could go back
Yes.
to school. I really didn't know if I can go back to school, but
No, you in fact, if deep down, if there's a burning desire where you feel this like I feel like I'm called to more, go for it. In fact, one of the things that you guys hear me talk about Dr. Francis, my mentor. So after when I had gone through my first 2 years of medical school, and then that's when I first met Dr. Francis. By that point, I was just feeling defeated because
yeah,
medical school beats you down. It just takes your life away because you're like 7 days a week. I mean, even on weekends, like weekends, you just don't have lectures, but you study for 8 hours a day, even on weekends. And I remember getting to Dr. Francis, and the very first session, I'm sitting there. I'm the front row student kind of guy, like close to the
same.
professor. And I'm sitting there on that front row, like right in front of Dr. Francis. He's standing there at the lectern. And he says, I'm going to teach you the most important concept in all of medicine. And I'm like, yeah. And no, what happened is in that first day, well, the first 4 hours was kind of introductory, like this is the program, this is what to expect, that kind of stuff. And then the next 4 hours is when he got into actual teaching. And sure enough, that very first day, I remember because I stayed in student housing, but for the first week, I had to stay in a hotel until my apartment came available. I remember calling my mom as soon as I got back to the hotel room. I was like, "Ma, I don't know who this guy is. I don't know what kind of magic trick he just did, but I'm so excited to learn." And
He's my
she's like,
hero.
"Son,
Yeah.
say that again."
Be like, he's my hero. Like,
Yeah.
yeah, all amped
And
up. Yeah.
so and Dr. Francis has become like a dad to me. He really is my hero because he made learning fun again. He was
Mhm.
connecting things that I never knew before. Like I knew information. I knew a lot of information. Like you don't becoming a doctor. I mean, you have to be somewhat intelligent, right?
Yeah.
but but it was just that they just cram so much information down your throat, but they don't show you how to connect it. And
Mhm.
Dr. Francis taught me patterns, and then I took what he taught me, and then I just built on it because he taught me to go back and learn normal. He said, "Go back and learn normal for yourself, and abnormal just smacks you in the face." And when I took the time to go back and learn the physiology and the biochem of normal, it's so much easier for me to understand all kind of abnormal situations because I'm not memorizing a lot of stuff. I just know normals, but I know normals so well that it's easy for me to recognize abnormal.
Yeah.
And suddenly, what you find is the better, the better, the better you get at learning, everything becomes easier. So it'll now be like I promise you, as a result of what you've learned from me, of course, I couldn't teach you everything I know because I don't have that kind of time. But even the foundation that I've started to lay, it will make it easier for you to go to PA school, nursing school, medical school. And because all that is just more information. It's more stuff that you don't know. And in fact, as you get deeper in your learning, you realize how little you do know, right?
Yeah.
Like a lot of paramedics feel like they know it all. And I'm like, oh
Mm.
man, if you only knew. And
Yeah.
hey, well, I've actually got to get on to
Yeah.
this next training, but it was a pleasure working with you. Take some time to go through the comprehensive study guide if you want to, but
Mhm.
you're in good shape. Just go
Okay. I
pass
really
this
appreciate
test.
you though.
You are certainly welcome, and stay in touch with me. Let me know. I'll be expecting to hear from you Saturday. If you have questions before then, don't hesitate to reach out. I'm in training all day the rest of today and tomorrow. I'll be traveling Friday and Saturday, so it may take me a little while to respond, but I will respond as quickly as I can.
Okay. Thank you.
All right. Okay, no problem. Have a great day.
You too. Bye.
Okay, all right. Bye bye.